Hi, everybody. This is the recording for prenatal care and adaptations of pregnancy. So we're thinking about prenatal care. We are thinking about our different phases. So antepartum is before birth of the baby, intrapartum is during the birth of the baby, and postpartum is after the birth of the baby. Our pregnancies are consisting of 13-week trimesters. All right, so that gets us 39 weeks. All right, and an actual term pregnancy is considered 40 weeks. All right, best case scenario is we have moms that are getting preconception treatment. This is a whole thing that that if we can get a handle on comorbidities with women before they become pregnant, that it decreases our incidence of high-risk pregnancy. It decreases our babies that are in the NICU. There's a lot of benefits to women getting treatment and seeking care before they become pregnant. Also, then they can start on their prenatal vitamins. There's a benefit to folic acid before pregnancy that we'll talk about, and a lot of those things. Okay. Prenatal care happens during the pregnancy. And so she will typically start seeing a provider as soon as she finds out she's pregnant. She can get a pregnancy test and they can determine that she's pregnant, get her started on her vitamins if she's not already done so. And then definitely if she has not started prenatal care by this point, we definitely want her being seen by week 12. Okay. And so prenatal visits happen about every month for the first 20 weeks of pregnancy, and then it becomes more frequent depending on if they're high risk and things like that. And so prenatal care is going to give us a lot of benefits because it's going to promote health of the pregnancy. It's going to promote health of the baby. It's going to keep everybody safe. It gives us a lot of time to provide education. There's so much education that comes into this and help them prepare for becoming parents. So our initial prenatal interview requires us to consider so many different things. We want to know her health history. We want to know her how her periods run. We want to know what her obstetric history is. We want to know if she's using contraceptives, if she's using drugs, if she's using alcohol, if she's using cigarettes, tobacco, things like that. Is she taking medications at home? Supplements, herbs, all of these things that can affect the way she grows her baby. We're going to start asking intimate partner violence questions with every single appointment. So we ask them questions. They are very specific. And a lot of hospitals and doctors' offices now have gone to having the mother use the bathroom, or which we usually get a urine sample anyway. And then there's a way that they can write on their urine sample if they're in danger. Or they'll also take the mom back and leave the partner out of the room and ask the intimate partner violence questions beforehand. Asking these questions, it definitely is going to depend on where we are in her cycle of violence, how open she might be about this. But the HITS acronym, are you with someone that hurts, insults, threatens, or screams at you? These are things that you can ask very specifically. We also can ask things like, are you in danger of being hit, kicked, punched, slapped, those things. Also, do you feel safe where you live? Sometimes it's not necessarily the person who's with them, it's somebody else, or it's the environment they live in, or whatever. So these are all important questions to ask. We're also screening for human trafficking and things like that. Other considerations, we're considering culture, and so what their cultural needs are and how we can meet them where that's important to them. And we're going to be obtaining lab work at that first prenatal visit. So we want to know that we want a CBC, or a complete blood count. So we want to know if she's anemic. We want to know also where her values start out. And so that then when we compare them when she goes into labor, we know how she is with her platelets, how she is with all these things. We're screening for HIV at the very beginning. Every woman, it's not, regardless of history, because that if she is HIV positive, we can give them a medication, an antiretroviral called Zuvudine, that helps decrease the transmission risk to the fetus. And then she would also get that medication in labor, and then the baby would get it after delivery. So we screen for that. We screen for rubella, if they're immune or non-immune. Most people have been vaccinated for rubella in their life, but sometimes they're not still immune. And rubella is one of those vaccines that is a live virus. So if she is non-immune, we don't want to vaccinate her now. However, rubella is also not something that women would like to contract during pregnancy because it has a lot of adverse effects to the baby. So giving her rubella vaccine after delivery when I know she's not pregnant is a good plan. So we're going to test and see if she is rubella immune or non-immune. We're testing for RH. What is her blood type? Is her blood type RH positive or RH negative? And we're going to look at that more in a little bit. But basically, if the mom's RH is negative, then that affects the way we take care of her. Okay. We're going to be doing a lot of education opportunities. We're going to start now. So we start teaching about some normal discomforts of pregnancy that we're going to learn about today. We teach about things like safety in pregnancy, that like for travel, for wearing your seatbelt, for a lot of different things. We teach about breastfeeding early on, probably not at the initial appointment. We teach about what she can expect for her prenatal care, what needs to be checked every month versus what we do periodically, and start having her think about what her plans are, where she wants to deliver, if she wants to deliver at home or in a hospital, if she wants a doula, all sorts of different things come into that. We're going to look at that somewhere. We're also in this initial interview going to determine her due date, okay, based on her last menstrual period. We're going to look at that, and we can then determine the gestational age of her baby. So this is Nagel's rule. This is a way of calculating the due date by using the last menstrual period. Now, if your patient doesn't have regular periods, Nagel's rule is not going to be quite as accurate, right? But this is based on a 28-day cycle. And what we do is we take the date of the last menstrual period, the day it started, and we're going to deduct 3 months from that, and then we're going to add 7 days, and then we add a year. And so this is going to give us the estimated date that she would be delivering at 40 weeks. So here's a chance to practice this. If her period was September 19th, Nagel's rule says that her, oh my gosh, that her due date is what? So if we did September 19th minus 3 months. And so if we say April, May, June, July, August, September, then we go back 1, 2, 3, we get June. And then we're going to add 7 days. 19 plus 7 equals 26. So our estimated due date should be, June 26th. And then we have to make sure we add the year, right? So we have June 26th option as A and as C. But if her period is in September of 2013, she's not having a baby in 2013 in an earlier month. So it's going to be 2014, or yeah, 2014. So C is the answer. Okay, so for our prenatal visits, so every single appointment, we're going to check her weight. We are looking at how much weight she's gaining. Okay, in the first trimester, she doesn't gain a lot of weight, maybe 4 pounds. And then after that, they usually gain about a half a pound to a pound a week. And so for your patient who has a normal BMI to start, she's going to gain about 25 to 35 pounds. So we're watching her weight gain to make sure that she's gaining weight kind of appropriately in that range. We're going to check a urine dipstick. We're looking for protein. We're going to learn later in the term about how protein can be a sign of a high-risk pregnancy. Okay, and then we're checking her vital signs, especially the blood pressure. An elevated blood pressure or blood pressure that is continuing to go up is also a warning sign for us. So this is something we check with every appointment. Other things we're doing, we have other tests that we do periodically, not at every appointment, like our ultrasound that we'll look at in a minute. We usually do that at 20 weeks to do like a review of systems. We could start doing fundal height at about 20 weeks. And so there's a picture of it on the slide here. And the measurement of the fundal height is going to give us an idea of how the baby's growing. And so we measure from the symphysis pubis up to the fundus, or the top of the uterus. And we anticipate that that measurement is going to be pretty close to the gestational age of her pregnancy. So if she's 24 weeks pregnant, we anticipate 24 centimeters on our measurement, and it can be plus or minus 2 centimeters. Before 20 weeks gestation, I'm probably finding that fundus below the belly button. And so, and we can't even really palpate it out above the pubic symphysis until around 12 weeks. And so it just kind of depends on where she's at in her pregnancy. We don't usually even start trying to measure until after 20 weeks. If we are measuring and we're towards the end of pregnancy, when the baby drops down into the pelvis, this is called lightening when the baby drops, then that measurement might change and it might feel less now because the baby has engaged in the pelvis. So that is fundal height. Intimate partner violence again. Normal discomforts of pregnancy. There's a whole bunch in your book. We're going to look at a few of them today. We're going to start talking, as I mentioned, about perinatal classes, whether they want to have a doula. And we're going to learn more about doulas in a different week, but doulas are really helpful for labor support. Do they have a birth plan? What birth setting do they want? Lots of education happening. We start asking about breastfeeding early on because this is something this is a good place for education. This provides immunity to the fetus, or well, to the newborn. Breastfeeding does because of the immunoglobulins in the colostrum and the breast milk. We teach about Kegel exercises, where you teach them how to contract like they're trying to stop their stream of urine, and that helps build the muscles that help support decrease stress incontinence and help support the pelvic floor. We teach about exercising, that mild exercising, like non-impact exercises, are important to do. It helps with their musculoskeletal development. It helps their decreased discomfort. It helps their body kind of be prepared for labor. It helps them return to their pre-pregnancy weight after the baby's born. But we don't want them doing high impact exercises. So not things like, some women still run through pregnancy, but switching to walking towards the end is a good idea. Things that are low impact, like swimming and yoga, are good ideas too. And then safety again. So, importance of wearing a seatbelt, where to put the seatbelt as their belly's getting bigger, what to do if they want to fly. So pregnant women can fly all the way up to 36 weeks, but since pregnant ladies are hypercoagulable, which we're going to also talk about on another slide, encouraging them to flex and their foot and keep their feet moving to decrease the risk of developing blood clots in their calves is a good idea, things like that. Most of our practice questions we're going to do in class, so I'm going to move on. Additional considerations. So other things that we're doing, not every time, but sometimes. All right. So for example, ultrasound. Ultrasound is something that is going to be done periodically. We often do an ultrasound early in pregnancy to help determine the due date. So even though Nagel's rule gives us a really good idea of the due date, an ultrasound is much more accurate in the first trimester to determine the actual gestational age of the baby. Review of systems. This is what we usually do at 20 weeks. And so 20 weeks, this appointment, they do an ultrasound and they look through the baby, they look through all of the systems. They look to make sure that everything is functioning properly for the baby. And then we can also use ultrasound for different reasons. So the two first ones are the most common, but we can also use ultrasound to measure the length of the cervix. Like if we're worried that she is going into preterm labor, we can do Doppler blood flow studies. We can check. So if we did, for example, if we did a fundal height check and that measurement was low, an ultrasound would be a good way to look at the baby and see how the baby's growing and see if we have an intrauterine growth restriction. Or if the measurement was high, we could also check to see if we have a baby that's large or macrosomic. We can also check our amniotic fluid levels to make sure they're normal. Okay. Urinalysis. This is something that we do at usually 12 and 16 weeks to just determine if they have a urinary tract infection that they're not having signs and symptoms of. And so the reason for this is because if they do get a urinary tract infection, it can cause them to have contractions and cause preterm labor symptoms in their pregnancy. 3-hour glucose tolerance test. So if a woman is not diabetic when she becomes pregnant, she does have the risk that she could develop diabetes during her pregnancy, and this is considered a gestational condition. And so we test these women at around 24 to 28 weeks to determine if they have gestational diabetes. And so the glucose tolerance test is a drink. It's a really sweet drink, and then they do a blood test, and then they check their blood sugar. And the 3-hour glucose tolerance test is going to identify if we have a patient that's got gestational diabetes. RhoGAM, or Rh immune globulin, is something that is administered at 28 weeks gestation for a woman if their blood type is Rh negative. So Rh incompatibility, we have it on another slide, but if the mom's blood type is negative, we don't know if the baby's blood type is an Rh positive, and if that were the case, the mom's body can build antibodies that go against that next pregnancy. And so even though it's not going to affect the current pregnancy, we need to, from the very beginning, from 28 weeks, and then at delivery of the baby, we want to keep that immune response from happening. And so that's what RhoGAM is for. So women who are Rh negative get RhoGAM. We teach women to do daily fetal kick counts. And so we start that at 28 weeks, where they just feel when the baby's moving. They keep track at the same time each day. They want to feel 10 movements in an hour. If they don't feel 10 movements in the first hour, then we encourage them to drink some juice, lay down on their left side and pay attention and see if they notice some movements, because maybe their baby had been taking a nap previously. And so this is a way that we can determine fetal well-being just from her at home. Group B strep is something that we test for at between 35 and 37 weeks. Group B strep is a bacterial infection that can come and go. It lives in the normal flora. So it doesn't affect women when they have it. any more than like if you have bacteria on your skin, on your hands or whatever. But it has a high neonatal mortality rate, which means that it up to 50% of babies that contract it could die. So we test for this, and if the mom's GBS is positive, we know that she is going to have antibiotics during labor for that reason. And then Leopold's maneuvers is another thing that we do to just determine the position of the baby, whether the head is down or not, and what position the baby's in. And that helps us also know where to put our monitors. So here's a picture of Leopold's maneuver. So you can see how they're feeling on the top and then down the sides and at the bottom. And so this gives us an idea of how the baby's laying. This can also then, when I said where to put our monitor, if I want to listen to the heartbeat, I want to put it closest to the baby's heart. So if I determine that the baby's back is like in this picture, on the bottom picture on D, the back is on the mom's right, then and the head is down, I would put my monitor on that low spot on the right side. Okay, next concept is gravidity and parity. So gravidity is the number of times the woman's been pregnant. And it doesn't matter what the outcome was. It doesn't matter if she delivered or not, if she had a miscarriage. The pregnancy is what counts. It also doesn't matter how many babies are inside, if it's a multiple pregnancy or not. It just matters that the pregnancy has happened. Okay. And so that's gravidity. And then we break down the terminology further and say that if she's pregnant for the first time, she's a prima gravida, because prima means one. If she's had 2 or more pregnancies, she's a multigravida. And if she's never been pregnant, she's a nulla gravida. Parity is the number of times when she has had delivered her pregnancy after 20 weeks gestation. Okay. And the reason that it matters about after 20 weeks is because prior to 20 weeks, it's considered an abortion. Whether it's a spontaneous abortion or a termination, the baby hasn't reached an age of viability. So parity only is counting from 20 weeks and up. Okay. And so again, this is going to also have breakdown in terminology and say prima para is if she's had delivered one baby that's over 20 weeks gestation. Multipara is if she's delivered more than one baby that's over 20 weeks gestation. And a nullipara is a woman who has not completed a pregnancy with a viable baby. So less than 20 weeks. So we actually will also write that as a G and P. So G for gravidity and P for parity. So in the hospital, if somebody says, I have a patient coming in, she's a G2P1. I know she's been pregnant twice and she's delivered once, more than 20 weeks. And so in the hospital, she's pregnant. That's why she's coming in. But that might not be true depending on when you're discussing obstetric history. And so that's kind of how gravidity and parity works. Now we're going to break it down even further. So if we say that we want to know her full obstetric history, we want to know her gravidity and parity, but the parity, we want to break it down even more. So the G is still the gravida or the gravidity. And then for parity, we are going to say T for term, P for preterm, A for abortions, and L for living. And so term is more than 20 weeks, or I'm sorry, term is greater than 37 weeks. Preterm is between 20 weeks to 36 weeks and 6 days. Abortions is 20 weeks or less, so 19 weeks and 6 days and under. And then living is all of the living children. Okay, So this can be where we pick up a twin. All right. So if you have a baby, or if you have a patient who is pregnant with twins and she delivers, her pregnancy counts the twins as one pregnancy and her delivery counts as one delivery, but the twins counts in the living. So we can have a G1 T, let's say she delivered after 37 weeks, T1, so she had a term delivery. Preterm delivery is a 0, abortions is 0, L2. Okay. All right, signs of pregnancy. So for signs of pregnancy, we have different terminology here. If we think about presumptive signs are subjective information. These are things your patient tells you. I missed my period. My breasts are tender. I feel sick in the morning when I wake up. Sometimes they can even say they think they feel their baby moving. And those little first movements, usually around 18 to 20 weeks, is called quickening. But quickening is still a presumptive sign because it's something she feels, not something I can assess. Okay. So these are all presumptive. She presumes she's pregnant because of these reasons. All right. Probable signs are she's probably pregnant. This is objective information that I can assess as her nurse. So if I do a pregnancy test in the clinic and it comes back positive, then she's probably pregnant. Okay. Another thing that we look at that are probable signs of pregnancy are things that cause changes in her cervix and in her vaginal area and in her uterus. And so these are also probable. So we have different ones. Chadwick sign is one that causes a bluish discoloration. And so the cervix, the vagina, the vulva, everything takes on kind of this purplish hue. Okay, that's Chadwick sign. Goodell sign, Hagar sign, and McDonald sign are all softening of different areas. So softening of the cervix, softening of the vagina, softening of the lower uterine segment, those things. Okay. Braxton Hicks contractions. These are where the uterus is contracting. You could palpate that and assess that as a nurse. So those are probable signs of pregnancy. The uterus is enlarging. She's probably pregnant. These are all probable signs. Okay. But I am not positive she's pregnant unless it is attributed to the baby. Okay. The positive signs of pregnancy are things that come from the baby specifically. So being able to hear the baby's heartbeat with a Doppler, being able to see the baby with an ultrasound, these things that are coming directly from the baby are going to be positive signs of pregnancy. Okay, so now the body goes through a lot of changes during pregnancy. One of the things that happens is circulation changes. And so what happens in the body is that the blood volume for mom is increasing by a lot, by 30 to 50%. And so her heart rate can go up because she's got so much more volume, and her cardiac output can go up because she has so much more volume. Her blood pressure should not go up, okay? Because the body also is releasing hormones that help it kind of, the vasculature relaxes and accommodates this extra blood volume. And actually that same hormone causes the joints to relax and makes her kind of waddly as well, which we'll look at in a minute. When the blood volume goes up, we get more plasma than we get red cells. And so it causes what we call a physiologic anemia. So her hemoglobin, if it is less than 11, she probably has a physiologic anemia. If it's less than 9, she probably has an iron deficiency anemia, and then she would need iron supplements. And iron deficiency anemia is the most common anemia in pregnancy. Pregnant women are also hypercoagulable, so they have a higher risk of blood clots. So they shouldn't sit for long periods of time. And if they're going to be sitting for long periods of time, this is what we were talking about with if they're on a plane, they should be moving their feet around and help keeping that blood flowing. Okay. And then the other thing that can happen, guys, is called supine hypotension. Supine hypotension is also referred to as vena cava syndrome. And if you look at the picture on the slide, you can see these great vessels coming down from the heart, and they run right back behind this big, heavy uterus. So if this mom lays down, or we put her on her back to check her fundal height, or anything that has her on her back, it's decreasing blood flow. Okay, it's putting pressure on those vessels. And so a couple of things happen with this. Number one, it decreases circulation to the baby. Okay, because those vessels are feeding the placenta all that blood flow. And so those babies, the baby can actually become hypoxic if this goes on for a period of time because of this reduction in circulation to the baby. Also, it changes mom's blood pressure. So that's where the supine hypotension comes in. So she can feel faint, lightheaded, dizzy, agitated. And so if she's feeling these feelings, we should encourage her to change her position. Turning on her side is going to fix the problem. Okay, because that's going to take the pressure off the vessels. It's going to perfuse the placenta, oxygenate the baby, and make her feel better. Okay. So additional changes. So here's again the common discomforts of pregnancy are in your book. Here is a snapshot of some of it. Okay. Respiratory wise, we can have nasal stuffiness. Sometimes women are more prone to nosebleeds because the capillaries get really engorged and because we have all that blood volume, right? On the skin, we can see different changes happening. So we see pigment changes. Pigment changes, the main ones that happen, linea nigra happens on the belly. So it's like a dark line that goes from the belly button down towards the pubis. Also, the areola can become darker on the breasts. Striae gravidarum is stretch marks. This tends to be something that a lot of women try to prevent, but some women don't get them and some women do. Itching can be a common thing in pregnancy. At work can be something that's concerning depending on the cause. Urinary frequency and urgency. Early in the pregnancy, this is caused by all that softening and all those things that we were just talking about here. If you see Hagar's sign, softening of the lower uterine segment, it causes urinary frequency in the first trimester. So in the third trimester, it's because you have this big human sitting and putting pressure on the bladder. So women in their third trimester can have stress incontinence. They can also have just leaking in general, even if it's not related to like coughing, sneezing, and stuff like that of urine. Gastrointestinal. So a lot of women in pregnancy have GI changes. So they have constipation, they have bloating, they have nausea, vomiting in the morning, things like that. Musculoskeletal. So I mentioned that when the blood volume goes up, the blood pressure shouldn't go up because the body releases a hormone that helps things relax. Well, it relaxes the vasculature, but it also relaxes the joints. And the pelvic joints are nice and relaxed to make room to accommodate this growing baby, but this can also cause some joint instability and cause the women to kind of waddle. Okay, lordosis, this is back pain. So if you think about kind of that sway back, that women that are very pregnant, their center of gravity changes and they have to accommodate for that weight. And so that can cause some back pain. That's normal. Neurologically, carpal tunnel syndrome, paresthesia is just because of the excess edema in their body. And then endocrine changes. So there's a few things happening here. Progesterone, estrogen, and HCG are all produced by the placenta, which we're going to look at that. But they have very important jobs. So progesterone maintains the pregnancy. Okay, so think progesterone protects. It helps keep her pregnant. It inhibits uterine contractility. Estrogen stimulates uterine growth. So estrogen enlarges. Okay. And then HCG is going to be a hormone that starts to be released with implantation. So when the fertilized egg comes down through the fallopian tube and implants in the upper portion of the uterus, the body starts producing HCG, and this is actually what we can use to detect pregnancy. That's what your pregnancy tests are looking for, is HCG. Oxytocin causes the uterus to contract. So it is not really prevalent until the end when we need her to be in labor. And then it's also something that helps the milk let down with breastfeeding. So here's a few of pregnancy changes and how things shift around in pregnancy. All right, so nutrition. So for nutrition, there's a lot of dietary considerations for pregnancy. Okay, there's certain things that are important for moms to have adequate intake of. Like DHA helps the baby's brain development. So things like salmon and eggs and chicken and things like that help with DHA. Folic acid. So folic acid is something that reduces the risk of neural tube defects. And it is especially helpful if she is taking it before she even becomes pregnant. And then in those first few weeks of pregnancy, because the neural tube actually closes at, I think, week 9. Okay, I think that we talked about last week. I think the neural tube closes at week 9. So oftentimes this is like right at the end of the embryonic period. And so taking folic acid during this time and increasing her folic acid intake with dietary is a good plan for her. Iron. So iron deficiency anemia is the most common anemia in pregnancy. If she is anemic, then she will need iron supplements for 3 months until the anemia resolves. And so a few things that we're teaching is going to be how to take iron if she's on iron. So she's going to need to take it for a while. So during this time, we're going to teach her things that help with absorption, like citrus fruits like orange juice, and to avoid things that decrease absorption like coffee and tea and milk. Okay. Milk and tea and coffee reduce absorption. Citrus fruits enhance absorption. For nutritional requirements, women should have about 350 to 450 calories per day in the second, third trimester. But truly, guys, it's more related to her diet choices, making good food choices, and then we watch the weight gain and have her kind of adjust what she's eating to get the correct weight. Because if I say you need 450 calories more per day, she could drink a Coke and say, nailed it. But that didn't do anything for her and her growing baby. For breastfeeding, women need 500 calories per day additional. Normal weight gain. So when we think about weight, they are looking at a BMI. And so you can determine the BMI with a mathematical equation. But typically, if a woman's BMI is in the normal range when she gets pregnant, she should gain 25 to 35 pounds. The first 4 pounds of that happens in the first trimester, and then about a pound a week thereafter. If she is obese with a BMI greater than 30, then her weight gain will be less. Okay. Other dietary considerations are going to be dependent upon conditions. So, like if she has gestational diabetes, that's the thing we were going to test for with the glucose tolerance test. Then it's important that she maintains consistent blood glucose levels. And so we teach them how to eat small, frequent meals and keep their blood glucose levels steady. Constipation and bloating is a normal discomfort of pregnancy. Things that they can do for this is going to be walk more, intake fluids, so make sure they're drinking a lot of water, and then fiber, fruits and vegetables. Heartburn is common in pregnancy. With heartburn, we want to encourage them to do small, frequent meals throughout the day, avoid spicy foods, avoid acidic foods. Don't eat a big meal and then lay down. And warm tea can help too. For nausea and vomiting in pregnancy, this is really common in the first trimester. And the thing that helps the most is going to be to eat like dry carbs first thing before they even get out of bed. So like crackers on the nightstand, A little baggie of Cheerios, something that you can eat before you even get up, is going to be something that will help with that. There's also antiemetics that can be prescribed, like Zofran. And there is ginger, like ginger pops, ginger ale, acupressure, so C-bands, things like that to help with motion sickness can help. So lots of different things that we can teach to help with morning sickness. And then pica. Pica is something that is caused by iron deficiency anemia typically, but it causes women to intensely crave non-food items. Like they can't not eat them. And we're talking about things that you wouldn't normally eat, like dirt and clay, chalk, starch, freezer frost. I'm trying to think. I've even had students in class that have told me different things they've craved, and I'm trying to remember them all. But it's just, it's not healthy for a lot of reasons. Number one, it's not healthy to eat those things, but then their body is getting full on these non-nutritive items. And so even if they're eating ice like constantly, they're not eating healthy food. So if you have a patient that has pica, then you need to assess the extent, like how much are you eating? And then you also need to notify the provider because we need to test them for iron deficiency anemia. And typically, if we get them on iron supplementation, as the anemia resolves, the pica resolves as well. For adolescent pregnancies, adolescents have an increased risk of low birth weight babies. They have an increased risk of anemia. They have an increased risk of having their perceptions of weight gain is different. They don't want to be fat. They also don't usually make good food choices. Their body's still growing, so their body's using the nutrients for their own growth in addition to growing a baby. So for all of these reasons, it is really important to have a dietitian involved with an adolescent pregnancy. Psychosocial adaptations. So there's a few things that go with this. It's a little bit different for the mom than it is for the dad. So we have, for the mom, there is sometimes some conflicted feelings when she first finds out she's pregnant, and ambivalence is not uncommon. This usually resolves as the pregnancy progresses, and especially once they start feeling the baby move and the baby becomes more real and she starts taking on this new role. And then the third trimester, they kind of get tired of being pregnant. They're kind of over it. They start having some labile mood swings. For dads, pregnancy is a much more abstract concept for the father. And so the way that they view it is a little bit different. So the announcement phase is when the pregnancy is confirmed. They can have some ambivalence as well, and going, oh my gosh, how am I going to support a baby? Am I ready to be a dad? But this is the announcement phase. This is when they come to terms with that, and now they want to tell everybody, and they want to share the information and announce. The adjustment phase, now they're starting to look at, okay, so I need to make these changes to our finances. I need to figure out how I'm going to support this kid. They want to become involved in the planning, maybe to help lay out the room. They want to come to the appointments. They want to put their hands on the belly and feel the baby move. And then the focus phase is when they start really participating like in everything and wanting to be part of the birth process and really start feeling like a dad. So here's your ABO and your RH incompatibility. So RH incompatibility, we spend a lot more time on. Okay, so I'm going to talk about that one a lot during the term, but I do want to talk about ABO as well because they both can affect babies for different reasons. So with our RH incompatibility, we have a mom whose RH is negative. All right, and so what we're talking about with this is a D antigen. So you think about blood types, and we have A, B, and O. So A, B, and O. And then, or AB, right? And so this is an A antigen, this is a B antigen. O has none, no antigens, and then AB is both. Okay, and then we have, then if you're negative, there's no D antigen. And if you're positive, there is a D antigen. So if mom's Rh is negative, then she does not have it. Okay, so it's kind of like a plain glazed donut. If the baby is Rh positive, then that's like having a donut with sprinkles. All right. And so the plain glazed donut doesn't want to have sprinkles on it. So it can build up antibodies when the body notices these sprinkles. And that's not going to happen until delivery, typically, unless there's like trauma or something. And so what we do if mom's Rh is negative is we give the RhoGAM to keep the antibodies from building up. Because this isn't going to affect this baby, but it's going to affect a future baby if those antibodies happen. So the RhoGAM keeps the antibodies from building up. Okay. Now, so that's Rh incompatibility. Mom is negative, baby's positive. So we would give RhoGAM at 28 weeks gestation, and then we would test the baby at birth. And if the baby's blood type is indeed Rh positive, then mom would get RhoGAM again at delivery. If it turns out that the baby's Rh is actually negative also, then mom doesn't need to get RhoGAM again. Okay. Now, also true that if she was pregnant and she had a miscarriage, then in that scenario, she also would get RhoGAM because we would not know if the baby was Rh positive or negative. Okay. For ABO incompatibility, this one's a little bit different. And what happens with ABO is mom's blood type is O. Okay. And so babies can be, I don't know if my marker's working very well. Let me try a different color. Baby can be anything other than O. And if baby is A or B, A, B, or AB, then it's possible that mom's body could be sensitized to this. So this can affect the current pregnancy. Okay. And so if that happens, then mom's body can already have antibodies that are built up in advance that could affect the red blood cells for the baby if the baby's blood type is something other than O. So we can test for this by using a Coombs test. If we do the indirect Coombs test, this detects antibodies that mom has. After the baby's born, we can do a direct Coombs test, which is a direct antibody test or a DAT test. And this is going to determine if those antibodies are on the baby's red blood cells. And if they are, then that baby has a higher risk of jaundice because the antibodies are going to break down those red blood cells from the baby's red blood cells, and that causes a release of bilirubin that increases jaundice. So that's how there's not anything we give for ABO. We only have RhoGAM we give for RH. And the RH incompatibility is a much bigger problem. So the rest of that we will discuss in class, and I hope you have a great day.